So we can start this Fujita Alumni Association webinar. Thank you very much for joining. First of all, I want to thank Professor Yoko Kato for being here. Unfortunately, we don't have Professor Ishu Bishnoi, who was blocked at the hospital with an emergency, but we have the pleasure to have Dr. Hui, who is our host, and actually he will be also co-moderator with me today. Thank you, Hui, for joining. We also have, or at least we will have, hopefully soon, Professor Ashish Kumar, as usual. He is our commentator, and he will join hopefully very soon. And we have Dr. Kabulo and hopefully Dr. Virda and Dutta as discussants today. So before I start introducing our first speaker, who is Professor Miki Fujimura, and later on our second speaker, Dr. Opara, I would like to ask Professor Kato to give a few words as introduction for this meeting. Thank you, Professor.
Thank you, everyone. So welcome to the Alumni webinar. And today we are so honored to receive the Professor Fujimura Sensei. He's a great teacher, especially the MoyaMoya and also the vascular and also the hemodynamic of the brain, I think. And also the May, he just left our department. She did a great job with us. So we are very much looking forward to your 2 lectures. Thank you very much. Albert?
Thank you, Professor Kato. And we can start. Let me introduce Professor Miki Fujimura. It's a great pleasure to have Professor Fujimura here at our webinar. We met recently, so it's a particular pleasure for me. He is professor and chairman at the Department of Neurosurgery in Hokkaido University, Sapporo, in Japan. He completed his training in Japan, but he has also been postdoctoral fellow of neurosurgery at the UCSF in San Francisco and at the Stanford University. He is affiliated to a number of national and international societies, and the list is very long. His main academic interests are surgery for cerebral stroke, revascularization surgery for MoyaMoya disease, aneurysm surgery, and subarachnoid hemorrhage. And he also has a very great interest in molecular biology and translational research about cerebral infarction, intracerebral hemorrhage, traumatic brain injury, and spinal cord injuries. Today, Professor Fujimura will talk about the impact of revascularization surgery for MoyaMoya disease, surgical procedure, and recent clinical studies. I kindly ask Professor Fujimura to share his screen and start his lecture. Thank you very much, Professor.
Thank you very much for your kind introduction, Professor Velletti. So it's my great pleasure to be here. I would like to thank Professor Velletti, Alberto, and Professor Yoko Kato for giving me this opportunity. Today's topic is MoyaMoya disease. So, bypass surgery for MoyaMoya disease. Thank you. Okay. Do you see the next slide now? Okay.
Yes.
So yeah, I'm from Sapporo, Hokkaido, but I'm originally from Sendai, Japan. So I'm going to talk about the MoyaMoya disease. MoyaMoya disease is very important because this slide shows the current indication for the STA-MCA anastomosis, which is a very basic procedure in neurosurgery. But I would say MoyaMoya disease has the best indication for MoyaMoya disease, best indication of the STA-MCA anastomosis. Not only the ischemic onset MoyaMoya disease, but also the hemorrhagic MoyaMoya disease patient has a great benefit from the revascularization surgery. So I'm going to talk about this topic today. MoyaMoya disease has a 70-year history. The Professor Jiro Suzuki in Sendai named this intrinsic disease as MoyaMoya disease because it's like a puff of smoke, and its diagnostic criteria is the terminal ICS stenosis and abnormal vascular network formation. But what is very interesting is this slide shows a temporal profile of this, the progression of MoyaMoya disease. And it begins with the terminal ICA narrowing and compensatory development of the MoyaMoya vessel. But after that, there are a lot of the transdural or osseous collateral coming from the external carotid artery. And finally, the MoyaMoya vessels decrease and disappeared. This is a natural cause of MoyaMoya disease, temporal profile of MoyaMoya disease. But most of the patients suffer the ischemic symptom or hemorrhage at stage 3 or 4. So in this kind of patient require the surgical procedures. So anyway, the temporal profile of MoyaMoya disease should be understood by the neurosurgeon. So I would say MoyaMoya disease is the intracranial extracranial conversion disease with transitional MoyaMoya phenomenon. So first, I would show the very typical case of MoyaMoya disease. This is a stage 3 MoyaMoya disease, IC terminal stenosis and MoyaMoya vessel development. And she apparently had the hemodynamic compromise and ischemic symptom on the right hemisphere. So this kind of patient has the best indication for the surgical procedures. This is a very standard procedure of STA-MCA anastomosis combined with the indirect pyrosyngiosis, so-called encephaloduro-myosyngiosis. One of the pitfalls of MoyaMoya disease surgery is that the recipient artery is has a very fragile vascular characteristic. Vessel characteristic is very fragile, such as the medial layer thinness, and internal elastic lamina is compromised in patients with MoyaMoya disease. So we should be very careful to manipulate the recipient vessels, but it can be safely done with a gentle procedure. This is the single STA-MCA anastomosis combined with indirect bypass, maybe 3.5 hour surgery, which contribute a lot to the patient outcome. So in fact, this patient has the improvement of the cerebral hemodynamics on the right hemisphere 1 day after surgery. So this is the most recent guideline of Japanese guideline for ischemic onset MoyaMoya disease patient. Surgical revascularization is recommended for the ischemic onset patient, and STA-MCA bypass is recommended especially for adult patient. It's necessary to include the STA-MCA bypass for the adult patient. And what is more important is recent guideline also recommend bypass surgery for the hemorrhagic onset MoyaMoya disease patient, especially in patient with a posterior hemorrhage. Why posterior hemorrhage? But the reason is a posterior hemorrhage patient has a very poor prognosis, high annual rebleeding risk, as high as 17% per year, which is indicated by the Japan adult MoyaMoya trial. So this recommendation is based on the result of the Japan adult MoyaMoya trial, which is a randomized control study to examine the efficacy of the STA-MCA bypass to prevent rebleeding in adult hemorrhagic onset patient. We stratified the anterior hemorrhage type and posterior hemorrhage type, and if you look at the right panels, and the posterior hemorrhage patient has a very high risk of rebleeding, but STA-MCA bypass significantly reduced the risk of rebleeding in the posterior hemorrhage patient. Everyone has questioned why posterior hemorrhage patient has a poor prognosis, but now we know the result, the answer. The responsible vessel is so-called the colloidal channel. This kind of a dilated and extended colloidal artery, MoyaMoya vessels, has a very dangerous sign prognosis in terms of the rebleeding. This is a very typical figure of the developed colloidal channel. choroidal channel can be also recognized by the very simple MR angiography axial view. This is a choroidal channel, and if the patient has this kind of posterior MoyaMoya vessels, a patient potentially have a very high risk of bleeding or rebleeding. So STA-MCA anastomosis is known to reduce the development of the choroidal channel, which may contribute to the prevention of rebleeding. This is a recent understanding of the preventive effect of bypass for the posterior hemorrhage patient. I would show one patient. This patient had the choroidal channel, and in fact, she suffered posterior hemorrhage. So in this kind of patient also had the best indication for the STA-MCA bypass. I recommended her the STA-MCA bypass combined with indirect bypass. Recipient artery is as small as very small diameter at 0.6 millimeter, but this procedure can be completed by the secure technique of the STA-MCA bypass. Again, the recipient artery vessel wall is very fragile, so it's very the surgical procedure, bypass procedure, is completely different from that for the aneurysm surgery or atherosclerotic patient. We shouldn't affect the very fragile recipient artery during the procedure. Anyway, this patient had the very good prognosis, like patent bypass and improved cerebral hemodynamics. So the next question is, of course, yes, we know the STA-MCA bypass is very important, critical, but the question is, combined bypass is better, or STA-MCA bypass alone is sufficient? This is an important question because the indirect bypass also had a potential risk of complication. But indirect bypass alone is not effective for the adult patient, because only a limited patient, 50–60% of adult patients develop the pyrrhus after the only the indirect bypass. So anyway, it's necessary to include the STA-MCA bypass. So go back to the question. So the answer is my preference is a combined revascularization surgery rather than the direct bypass alone. The reason is shown in this slide. The combined direct-indirect bypass is known to have a result in the wider vascular territory supply, or favorable, better long-term outcome and better CBF improvement, also in the ACA territory compared to the direct bypass alone. So most of the Japanese institutions attempt the combined revascularization surgery for the patient with MoyaMoya disease. We have one more data to support this idea. This is the characteristic genetic variant among the East Asian MoyaMoya disease patient. And in Japan, 80% of the MoyaMoya disease patient has this characteristic, the single nucleotide polymorphism genetic variant. But what we found was that if the patient had this characteristic variant, the patient had a very good development of indirect bypass after the combined revascularization surgery. This panel shows the patient result of the patient with genetic variant, which apparently showed the great development of the indirect pyrrhus derived from the deep temporal arteries. So going back to the fact that 80% Japanese patient has this genetic variant, this result would support the combined revascularization is very reasonable for the management of MoyaMoya disease, at least in East Asian countries. So but it's still difficult to predict the development of indirect pyrrhus after combined revascularization surgery. So this is the most recent study of ours, and we focused on the MR angiography score. For example, this score 2, and look at this score 2 or score 3 patient has a very poor visualization of the peripheral vessels, ACA, MCA, PCA appearance. If the patient has such a very poor visualization of the peripheral cortical arteries, our idea is this kind of patient has the best much better development of pyrosynangiosis. We got the impression based on our experience. So we investigated the correlation between such kind of MR angiography peripheral visualization score with the development of the pyrosynangiosis after combined revascularization surgery. The results show that if the patient has the higher MRA score, which means a very poor visualization of the peripheral MCA, the patient would have a much better development of the indirect bypass after combined revascularization. So, in this article, we concluded that if the patient had a lower MRA score and also had the genetic variant of RNF 213, the patient would have a poor pyrosynangiosis development. So we can predict inversely, if the patient has a very poor visualization of cortical arteries by MRA, patient would have a better development of the pyrosynangiosis after combined revascularization. So anyway, based on the findings, we attempt the direct indirect combined bypass for the universally to the MoyaMoya disease patient. So I think some of you joined the 𝑦𝒐𝒑𝒊 Microsurgical Academy last month. I also joined the Istanbul conference to see the Professor 𝑦𝒐𝒑𝒊, the 99 years old, and I joined there and talked about MoyaMoya disease. And I also met a lot of the Turkish friends there. So I really like today's opportunity to extend the friendship to the worldwide in neurosurgery. So thank you again for this opportunity. So I would move on to my next topic. Next topic is the complication avoidance in MoyaMoya disease. In the first part, I explained that the MoyaMoya patient had the best indication of STA-MCA bypass, and combined revascularization is very powerful to prevent recurrent stroke in patients with MoyaMoya. But the complication avoidance is very important, especially in MoyaMoya disease, because we know that the patient has a higher risk of cerebral hyperperfusion syndrome, even after the low flow bypass. If we go back to 20 years ago or 15 years ago, no one believed that such kind of low flow bypass procedure result in the hyperperfusion syndrome. But we are the first to report this phenomenon in the large series, like this patient. Even after the successful low flow bypass, patient could suffer the neurological worsening due to their local hyperperfusion. And in this period, the blood pressure lowering was contraindicated after MoyaMoya disease surgery. But so I very carefully reduced the blood pressure in this patient, and I found the patient's symptom dramatically improved after the decrease of the blood pressure. So we recognize that the hyperperfusion phenomenon exists in MoyaMoya disease patient. And after that, we increased the number of the patient. And what we found was even after the same procedure, I mean the STA-M4 bypass, atherosclerotic patient had a very low risk of the hyperperfusion syndrome, but the MoyaMoya disease patient has a much higher risk of this phenomenon. So we found that this phenomenon is a very characteristic pathophysiology in patient with MoyaMoya disease compared to the atherosclerotic patient. So I would show a very typical patient. This patient underwent the left STA-MCA bypass successfully. One day after surgery, there is a very local hyperperfusion. But the patient was asymptomatic one day after surgery. But after that, the patient suffered transient aphasia and simple partial seizure. So we further reduced the blood pressure, and final outcome was very favorable. But the patient transiently suffered this kind of pathogenic edema. So this patient, the result apparently showed that this patient suffered the symptomatic hyperperfusion after low flow bypass. Finally, the pathogenic edema disappeared and patient was discharged without neurologic deficit. But in much more rare occasion, the patient may have this kind of a very deleterious result of the hyperperfusion phenomenon. This is another patient, the 40s female, and she underwent a very successful STA-MCA bypass combined with EDMS, but the patient has a very, very high, tremendous increase of the local cerebral blood flow at the site of the anastomosis. So we tried everything, reduce the blood pressure or neuroprotective agent, but ultimately she suffered the intracerebral hemorrhage, delayed intracerebral hemorrhage. It's very rare, less than 1% incidence among my personal series, but hyperperfusion syndrome could result in this kind of very deleterious result in a very rare occasion. So we attempted the quantitative analysis of the local cerebral blood flow and manifestation of the hyperperfusion phenomenon in the large series. What we found was if the local CBF increase was over the 180% compared to the preoperative status, patient could suffer the transient symptom, local symptom, local neurologic deficit. And if the local CBF exceed the 240%, which is a very remarkable, marked increase compared to the preoperative CBF, a patient could have the risk of the hemorrhagic conversion. So I think we believe that this kind of very local quantitative CBF measurement is very important to predict the result of the hyperperfusion syndrome. So nowadays, I'm wondering if the patient suffered such kind of very high CBF increase, I may attempt the sedation or the remarkable blood pressure lowering, although it has a potential risk of ischemic complication at a remote area. So, but anyway, this kind of complication avoidance is very important in a patient with MoyaMoya disease. So I summarize the management of cerebral hyperperfusion in MoyaMoya disease in this slide. Blood pressure lowering is very effective. But again, MoyaMoya disease patient has a bilateral lesion on the remote ischemia. So excessive, too much CBF, too much blood pressure decrease has a potential risk of remote infarction. So we should be very careful to avoid the excessive blood pressure lowering. But anyway, blood pressure lowering is very effective to manage the cerebral hyperperfusion. And some pharmacological agents are reported, like minocycline, which is the anti-inflammatory antibiotics to block the matrix metalloproteinase 9, which is affects the blood-brain barrier impermeability. And also the free radical scavenger is effective to reduce the risk of hyperperfusion. And I would finally explain the flow control bypass later on. So representative case of the posterior hemorrhage patient and simultaneous ischemia. I believe she has a definite indication of the left STA-MCA bypass. And she has a colloidal channel, which indicates a high risk of rebleeding. And this is the lateral view of the ECAG. Another pitfall is she has the transdural anastomosis preoperatively from the anterior convexity branch of MMA. So we should preserve this kind of collaterals during craniotomy. So I make craniotomy and around the parietal branch of the STA. So hemodynamic measurement is very important to decide the surgical indication. She had the apparent hemodynamic compromise on the left hemisphere. So I finally showed the little bit longer video. So STA, in most cases, I only use a single branch of the STA, and one branch of STA is preserved. After the dural incision, I found a favorable recipient artery. So I decided to cut the STA at this site. And we use aspirin before and after surgery. So, and I cut some of the branch and make a preparation. So this patient has the atherosclerotic STA. And again, the recipient artery has a very fragile vessel wall. So the issue of this procedure is not only the discrepancy of the diameter of the donor recipient, but the donor recipient has a very different characteristics. One is atherosclerotic and the recipient is very fragile, so-called negative remodeling. So we should attempt a very careful anastomosis. So you may recognize it's very different procedure, more gentle, much more gentle manipulation compared to the aneurysm surgery or something else. So I completed the anastomosis and IC green video angiography is very, very critical after this procedure. She had a very good rib distribution of the bypass blood flow. And finally, I combined indirect spiral syndangiosis and completed surgery. So after this kind of uneventful surgery, she suffered, she had a transient blood pressure increase, and at the same time, she suffered aphasia. So we reduced the blood pressure and the symptom disappeared. So this is a very characteristic finding of the symptomatic hyperperfusion. Even without the hemodynamic study, I can easily know she had a hyperperfusion phenomenon because the blood pressure lowering was very effective to improve her symptom. In fact, we simultaneously performed the CBF study, which indicate a local increase of CBF. And if the patient has the primary hyperperfusion, we should see the cross-cerebral diasthesis. If it is a seizure, the contralateral cerebellum should have a higher CBF, but she had a cross-cerebral diasthesis, decreased CBF on the contralateral cerebellum, so she had a definite diagnosis of the local hyperperfusion. So we performed the blood pressure lowering, and she was discharged without a good result. This is the last part of my talk. So one of the ideas is to make a flow control bypass. One of my friends in China attempted this kind of side-to-side flow control bypass instead of the end-to-side anastomosis. So it's a very preliminary study, but what we found was the side-to-side bypass, which is a flow control bypass, could have a lower risk of the local hyperperfusion due to its characteristic of the bypass flow control. So, but I personally do not try this procedure, but maybe he would increase his personal studies and report the effect of this procedure to prevent hyperperfusion syndrome. So it's exactly the time. So I would conclude the flow augmentation bypass is reasonable for symptomatic MoyaMoya disease patient, either ischemic or hemorrhagic onset patient. And number two, STA-MCA anastomosis with indirect pyrosynergiosis, so-called combined revascularization, could be a preferred procedure for symptomatic MoyaMoya disease patient. And number three, that we can expect enhanced pyrosynergiosis development if the preoperative MRA demonstrates marked signal intensity decrease of peripheral intracranial arteries after combined revascularization, and especially in patients with a genetic variant of RNF230. So in these procedure, in this way, we may expect the development of pyrosynergiosis after combined bypass. And finally, the prompt blood pressure control and the neuroprotective agent administration, and also probably the flow self-regulating side-to-side bypass could reduce the risk of cerebral hyperperfusion syndrome in MoyaMoya disease. So thank you again for this opportunity. I'd be happy to accept the questions or comments. Thank you.
Thank you very much, Professor Miki Fujimura, for this very interesting presentation. I personally was mesmerized by all the studies you have shown. Some are very, very interesting about hyperperfusion, about the impact of genetics. So I'm sure there are many questions. I personally have many. But I see we have a raised hand by Dr. Nirai Ymir. Please, you can ask your question, Dr. Nirai.
Hello, Professor.
Hello, I can hear you. Thank you.
Good evening. Good evening. Sir, I would like to ask one question. How to decide the recipient vessels in M4 territory of the MCA?
It's a great question. So the choice is very limited because the MoyaMoya disease patient has a very fragile M4. So I prefer to select the anatomically best vessels, recipient vessels, in terms of diameters, in terms of characteristic. If the vessel wall is very thin, the vessel wall color is like a vein, but the pinky M4 has a better, thicker vessel wall. So I may suggest choose the most healthy M4 as a recipient artery. But if you have some choice, I prefer the non-eloquent area. And another thing is supra-sylvian vessels, because we should prevent future hemorrhage. We should prevent the future hemorrhage. If we make a frontal or parietal anastomosis, you can reduce the choroidal channel coming from there.
Okay, thank you. Thank you, sir.
Thank you.
And Dr. Mikael Asgard.
I had the chance to meet you here in Japan and also in Cape Town, Tokyo. So I have some questions. The first thing is there any genetic difference between Asian and non-Asian MoyaMoya disease, and if it has any effect on the prognosis of the MoyaMoya disease? My second question is, how do you manage aneurysm associated with MoyaMoya syndrome and MoyaMoya disease? Do you do it endovascularly or open aneurysm management surgery for aneurysm associated with MoyaMoya disease? And my third question is, usually when you do bypass surgery for MoyaMoya disease, the distal M4 segments, they might be small in size. So the ST is large, the distal M4 is small. So the one of the flow on how the flow in small size M4 and large size ST. So the flow and the pressure from ST to MC, is there any effects with size discrepancy between the ST and M4 segments? The other question is, sorry, I have a lot of questions. I'm sorry. Do you have any tips like intraoperative when you do bypass surgery for MoyaMoya disease, like inhalational anesthesia or total IV anesthesia for the BP monitoring and like that? If there is any intraop tips for MoyaMoya bypass surgery.
Okay,
And
thank you.
okay.
Already
My
have
last question is,
that's good.
Okay,
good. I will begin with genetics. RNF213 genetic variant is characteristic in Japanese among Japanese patients and Korean patients, but not for the. It's not true in the Caucasian patient or other countries. So maybe some other genetic variant is correlated in the different countries. So we have a different genetic background between the Asian and European and many African patients. The next question is the aneurysm. So yes, as you suggested, the endovascular obliteration is better for the MoyaMoya disease patient at the circle of Weir's aneurysms. So, but in the peripheral vessel, like a choroidal channel microaneurysm, maybe some targeted embolization is also very effective. So anyway, endovascular surgery is very important for the management of MoyaMoya disease. And the third question, the vessel size discrepancy. STA and MCA has a very different size of the vessel. So it's a very good question. But I want to emphasize again that the vessel diameter discrepancy is not a big problem. We can anyway perform the anastomosis. But the biggest issue is vessel wall characteristic is very different. STA could have atherosclerosis and recipient has a very fragile, thin vessel. So it should be very managed carefully. So the last question, the intraoperatively, blood pressure maintenance, intraoperative is very important. And also the to avoid the hypercapnia, hypocapnia. CO2 control. So it's anesthesia is very important in the patient with MoyaMoya disease. Thank you.
thank you.
Thank you. I see there is another question by Dr. Medina. Let's see. Can you activate your? Yeah, you can talk, Dr. Medina.
Thank you. I have question. Well, Professor Fujimura, what do you think about using only revascularization to treat aneurysm without clipping or coiling?
Okay, clipping indication, clipping and coiling for the what kind of aneurysm?
Only revascularization without clipping or coiling to treat aneurysm.
Okay.
Yeah.
For the microaneurysm at the MoyaMoya vessel, direct bypass is known to disappear the microaneurysm. After revascularization, we can expect the spontaneous disappearance of the deep-seated smaller aneurysm. But it's not true in the sacral aneurysm. If the patient has a sacral aneurysm, especially in the ruptured case, it should be obliterated by the endovascular procedure. But about the microaneurysm and the deep-seated microaneurysm, you are true that the bypass can reduce the size of the aneurysm, or some aneurysm disappeared after revascularization surgery. So we can try bypass first.
Thank you. It's clear.
Thank you. And Professor Fujimura, I also have some questions. About indications, you said that you operate on symptomatic patients. Is there any role for bypass for patients who don't display symptoms yet? Do you have some specific indications for a subset of asymptomatic patients? The other question is about this RNF213 polymorphism. Do you use it only for a prognostic reason, or does this polymorphism have also some clinical or surgical impact? I mean, do you do indirect revascularization only in patients who display this polymorphism, or you do direct and indirect in all of your patients, irrespective of this polymorphism? And the last question is about hyperperfusion syndrome and hemorrhage. Do you suggest performing perfusion CT scan only for symptomatic patients after surgery, or do you think it's better to do that for all patients so you can have some image indications about how to manage the blood pressure?
Okay, thank you, Professor Fedeti. These are all excellent questions. I begin with the asymptomatic patient. Okay, if the patient has a very severe hemodynamic compromise, especially in children, they cannot complain their symptoms. So we perform bypass for the hemodynamic compromised patient, even though they are asymptomatic. Another point is a recent AMORE study, which is asymptomatic MoyaMoya registration, indicates that if the patient has a colloidal channel in asymptomatic patient, this kind of patient has a risk of the de novo hemorrhage. So one idea is to perform bypass for the asymptomatic patient with colloidal channel development. But so in some patients we do that. And I move to the second question. Okay, I perform the combined bypass irrespective of the RNF213, and at this time, because we cannot completely predict the development of pyrocinosis. And the last question is post-operative hemodynamic study is very important. So I want to emphasize, I routinely perform the single photon emission CT SPECT 1 and 7 days after surgery. I routinely perform it. So one day after surgery, if patient has a hyperperfusion, I may additionally perform some arterial spin leveling or something at the day 2, 3, something. So anyway, routine performance of hemodynamic study is important. Thank you.
Thank you, Professor Fujimura. Very important message for young neurosurgeons. We have a question in the chat. Is there a role of omental transplanting in the management of MoyaMoya disease, and when is it indicated?
Okay, thank you. Omental implant is very important. Professor Gary Steinbach reported it. And if the patient has a very poor donor artery or the recurrent stroke after surgery, omental transplantation could be one of the choice. And especially at the interhemispheric part, omentum can be introduced interhemispheric fissure. So it can cover the large territory. So it can have some role in this kind of patient. Thank you.
Thank you. We have Dr. Zulfikar. Please.
Hello, Professor. Can you hear me?
Yes, a little bit echoed, but
it was a very good lecture. My question is regarding the lowering the BP in hyperperfusion syndrome. Like, what drugs do we use for lowering the BP? Because in most of cases, like in essential hypertension, like if we are lowering the BP, so we initially lower the BP like initially 25%, and we lower the BP slowly. So what do we do in such cases in hyperperfusion syndrome? Like if we lower the BP a bit more than what we are targeting, the ACA distribution will be at risk of ischemia, because there is a competition of flow between the MCA and ACA after the bypass. So what is the protocol of lowering BP in such cases?
Thank you. It's a very critical question. My answer is it depends on the hemodynamic status of the remote area. If the patient has a contralateral severe ischemia, we should avoid the excessive blood pressure, BP lowering. So it depends on the hemodynamic status, even at the contralateral hemispheres. if the patient has a good hemodynamics, you can reduce the blood pressure. Lower, but in most cases, it's not allowed due to the contralateral ischemia. So, thank you.
Thank you, Dr. Kabulo.
Thank you so much, Professor, for this wonderful presentation. I really enjoyed your talk, and especially knowing that we can now do side-by-side bypass, which was a very good information. So my question was, do you only do it in MoyaMoya disease, the STA-MCA bypass, or sometimes you do it in ischemic stroke? And if you do so, when do you do it in ischemic stroke? Acute phase or after 3 weeks like others do? Thank you.
Okay, thank you. In the atherosclerotic patient with a severe hemodynamic compromise, we do bypass surgery for the atherosclerotic patient. But my principle is at the chronic stage and after 3 weeks, 4 weeks, as you suggested. But if the patient has a very unstable symptom in the acute stage, like a fluctuated symptom due to the hemodynamic compromise, in a rare occasion, I perform the STA-MCA single bypass for the patient in the acute stage. But it's very rare, and only one branch anastomosis in a very short time of surgery, 2 hours, 3 hours, in a short anesthesia time. But basically, I do that in the chronic stage. Thank you.
Thank you so much, Professor. Sorry, Professor, I can add one more question. When you do it like in an acute stage, or when you do it in a chronic stage after 3 weeks and 4 weeks, do you sometimes get hyperperfusion injury after 3 weeks?
After 3 weeks. Personally, not in the atherosclerotic patient. It's very rare, as long as we perform the STA-M4 bypass. But if we do STA-M3 or M2 bypass, I have some experience of the hyperperfusion, even in the atherosclerotic patient. But for the M4 bypass, it's very rare in the atherosclerotic patient. Thank you.
Thank you, Professor. What about the MCA malignant infarct? Do you perform also STA-MCA bypass? That's the first question. And also, if the patient need, for example, DECRA, can you perform both at the same sitting? Decompressive craniectomy, then you do STA-MCA bypass.
I never do that. I never do that for that kind of malignant MCA occlusion.
Thank you. Okay.
So Fujimura-sensei, thank you very much.
Thank you.
So maybe this is not my question, but you are the chair of the Japan Neurosurgery Society International Committee. So maybe you can just talk to everybody what you want to do in the future.
Thank you.
先生、国際委員会のチェアとして何か皆さんに若い人たちに何か今後どうしてあげたいって何か言ってください。
Okay, thank you for the opportunity. I'm the co-chair of the International Committee in Japan Neurosurgical Society. We are very, very willing to extend our friendship all over the world, especially in the all over the world. And so we want to organize a lot of the international webinar in the near future. So I hope everyone will join it. We would try to make it very educational and very interesting. So thank you.
Thank you, Professor Fujimura. Thank you very much. And as I don't see any other raised hand, I think we had a very fruitful discussion after this wonderful lecture. Extremely interesting topic. So I would like to thank again Professor Miki Fujimura for joining our Alumni Association webinar. And we can now move on to the following speaker, Dr. Opara, but I kindly ask Dr. Hui, my co-moderator today, to introduce our second speaker. Hui.
Yes. Hello, everybody. It's my pleasure to introduce Dr. 𝑦𝒑𝒊𝒏𝒊𝒂𝒓 from Nigeria. She's graduated from the medical school at the University of Port Harcourt in Nigeria in 2005. And then she did residency training in neurosurgery at Usmanu Dan Fodio University Teaching Hospital in Sokoto, Nigeria in 2018. She has recently finished her fellowship at Fujita Health University Bantaning Hospital last month. She's now working for 3 hospitals in Nigeria, Imo State Specialist Hospital, where she holds some leadership position. She's the head of Department of Surgery. She's the director of the ICU unit. She's the head of training research unit at the hospital. And the second hospital she's working for is the Federal Teaching Hospital in Owerri. The third hospital is the Federal Medical Center in Umuahia, in southeast of Nigeria. She is actively participating in local and international neurosurgical society. She's a co-chair of Young Nigerian Neurosurgeon Forum. She's the Secretary of Women in Neurosurgery in Nigeria. She's a member of Nigeria Academy of Neurological Surgeons, the Secretary of Young African Neurosurgeon Forum. She's a member of WFNS Neurotrauma Committee, and she is a co-editor of WFNS newsletter. She has authored or co-authored about 10 publications. Dr. 𝒂luwamaywa, please.
Thank you very much, Hui. I thought it was going to be a short CV, but that sounds quite long. Thank you so very much. I want to appreciate Professor Yokokato, Professor Felletti, and my colleagues here for this opportunity to discuss with us this evening. I just recently returned from Japan just about 2 weeks ago, and I don't know how many alumni here remember this place. Yes, this is where we usually have our welcome dinners for all of our fellows. And this was the welcome dinner for Dr. Zulfikar. Dr. Zulfikar, good evening. I have very wonderful memories of my time in Japan. And I think those were our last pictures a few weeks ago with Dr. Hui, Dr. Mikhail, and Dr. Zulfikar. So it's a very big privilege for me to share with us this evening one of the things that I worked on while I was at the Fujita Health University. The 2 months I spent there were very wonderful weeks. And one of the things that I observed was the carotid endarterectomy procedure. Now, I have read about it, but I had never seen one. And the opportunity of observing one during my training at Fujita made me go back to read around it again and look critically at why it's not being done in Nigeria, despite the fact that we have a high stroke rate in Nigeria, and also to consider what can be done to ensure the establishment of carotid endarterectomy services in Nigeria. So with that in mind, I would want to take my talk tonight using this outline. So by way of introduction, what is carotid endarterectomy? It's a surgical operation that involves making an incision in the internal carotid artery and common carotid artery for the purposes of removing a plaque causing stenosis within the arterial lumen. And it is done to prevent ischemic strokes as a result of that stenosis. The first CEA was attributed to Dr. 𝒂𝒂𝒄𝒕 of the United States in 1953. However, he didn't publish that case until about 19 years later. And because of that, there was a lot of argument over who actually started carotid endarterectomy and who did the first successful one. However, Dr. Iscott of the United Kingdom made the first publication in 1954. By 1971, less than 20 years later, up to 15,000 cases were done annually in the United States. And 5 years later, the number had more than doubled. In Africa, it's not documented where the first CEA was done, but there is a journal article mentioning that it's been done in Durban, in South Africa, since 1981. I don't know of other places where it is being done. I will assume that is also being done in Northern Africa, like in Morocco, that has a major neurosurgical center. I was discussing with a colleague last night, and he mentioned that he had done about 2 cases in Ghana. A few have also been done in Côte d'Ivoire, but there's no real documentation of a lot of these services in Africa. Now, with the increasing use of carotid artery stenting, CEA is not as popular as it used to be, and I'll show a graph very shortly. However, it still has its place and is the gold standard in the surgical management of extracranial carotid artery stenosis. Now, I got this graph from the internet about the carotid endarterectomy and carotid artery stenting in Japan. And if we look at the slide carefully, we'll see that in the year 2004, about 2,662 cases of carotid endarterectomy was done, compared with about 2,353 carotid artery stenting. In over 10 years after that, in 2018, carotid endarterectomy had increased to just about 4,000 cases, but carotid artery stenting had more than tripled, increased more than 5 times that number to 10,000, over 10,000 cases. So carotid artery stenting is being used more frequently. However, there is no study to prove that it is more, that it is better than carotid endarterectomy. So carotid endarterectomy still remains the gold standard in the surgical management of extracranial carotid artery disease. So I'll move on to talk about the indications for carotid endarterectomy. And this was important for me because I was wondering, is it that we don't have the patients? Why is it that it's not being done in my country? And then I got this from the 1995 guidelines for carotid endarterectomy, a consensus statement from the American Heart Association. They divided the indications into 4 groups: proven indications, acceptable but not proven indications, uncertain cases, and then definitely unacceptable case indications. So proven indications are patients who have had at least 1 transient ischemic attack or a mild stroke within the past 6 months with carotid stenosis in the same ipsilateral region of 70% or more. This is a proven indication for carotid endarterectomy, 70 to 99% stenosis. Acceptable indications include patients who have had TIAs or mild to moderate strokes within the past 6 months with a stenosis of about 50 to 69%, even on maximal medical management. There are many other indications there. Uncertain, we're not quite sure if it would really be helpful, are patients who have transient ischemic attacks or mild stroke with stenosis less than 50%. Or patients with transient ischemic attacks, stenosis less than 70, but they also have coronary artery symptoms that require treatment. It's not certain if carotid endarterectomy will be useful for them. And it is definitely inappropriate to use carotid endarterectomy in patients who have some stenosis, less than 50%, but are not on medical management, or high-risk patients with multiple TIAs not on medical management. Is definitely inappropriate to offer carotid endarterectomy. And the study keeps going on. There are many more studies coming up to help identify more patients who would definitely require or would definitely be benefited by carotid endarterectomy. Now I'll move on to the technique. The surgical materials and instruments are being used, intraoperative monitoring, and then the surgical steps. For the surgical materials and instruments that are needed, general tray containing self-retaining retractors, like wet liner retractors. Some will prefer to use skin hooks, and then sharp dissecting scissors, needle holders, and so on are needed. We also need vascular pickups, micro ring tip forceps to help to clear out the vessel wall after removal of the plaque. We need silastic vessel loops. Some would also want to have a carotid shunt available, and this is usually when the surgeon feels that intraoperatively he would need to ensure that there's still flow to that same side of the cerebral hemisphere so as not to cause an intraoperative stroke. So some people want to have a carotid shunt available. Some use it routinely, others use it only when intraoperatively if there is evidence of hypoperfusion after placing the clamps. We also need to have vascular clamps and clips and clip applicators available, and the sutures that we need. Some surgeons love to have to repair the atterectomy with a patch graft, and others don't. In the procedure that I watched, we didn't need to use a patch graft. And then magnification has become a part of the surgical procedure. Initially, people used loupes, but now with the advent of very good microscopes, more surgeons use microscopes for magnification for this procedure. Also, with the evolution of exoscopes, quite a number of people are beginning to use exoscopes instead of microscopes for this procedure. In terms of intraoperative monitoring, as I mentioned, because during the carotid endarterectomy, you will need to clamp on the carotid artery, which is a major blood vessel to the brain. And this procedure is meant to help to prevent strokes or subsequent strokes. By clamping the blood vessel, you could also cause a stroke, except you have adequate cross flow from the opposite carotid artery and the rest of the circle of Willis. So it's very imperative to monitor the patient intraoperatively to see if there's any evidence of hypoperfusion during the surgery. Parameters that have been used for intraoperative monitoring include a transcranial Doppler, electroencephalogram, near-infrared spectroscopy, intraoperative neuromonitoring with somatosensory evoked potential or motor evoked potential, and then stump pressure monitoring. And it's recommended that dual modality should be used. And intraoperatively, if there's any evidence of hypoperfusion in that region, there are specific things that can be done to help to ensure recovery of the perfusion to that part of the brain. In the procedure that I observed, we used the near-infrared spectroscopy and the somatosensory and motor evoked potential in monitoring the patient. Now to the surgical steps. Positioning of the patient. The patient needs to be positioned in such a way that we can see the area of the surgery clearly. So there should be some neck extension and lateral rotation of the neck to the opposite side. There are different discussions on how much neck extension is required and how much lateral rotation should be given. So I think the surgeon would need to decide on the appropriate one for his patient. Then skin marking is centered on the carotid bifurcation, with use of ultrasound localization to mark. It's the preoperative CT angiogram is very helpful to identify the level of the carotid bifurcation because high bifurcations may be a little bit more difficult to reach. And in fact, it said that if a carotid bifurcation above C2 may need to have endovascular treatment instead of open surgical management. In terms of the skin incision, the transverse skin incision is well known and it is more cosmetically acceptable. However, with the longitudinal incision, you have a wider exposure, and some people have talked about combining both. After making your skin incision, the layers you pass through include the subcutaneous fascia, and then you cut through the platysma, and then you meet the deep fascia. This diagram shows us the anatomical the anatomy of the area when we get in there. We should go anterior to the sternocleidomastoid muscle, and we should note that the greater auricular nerve crosses the muscle on its way to supply the parotid, and we need to preserve that nerve. The carotid sheath lies directly beneath the sternocleidomastoid muscle, and we usually would be able to see the common facial nerve as it crosses over the carotid sheath to drain into the internal jugular vein. This common facial vein needs to be ligated and cut to widen the exposure to the carotids. Then we can identify the ansa cervicalis and the hypoglossal nerve towards the upper side of the field. Then the next step is to dissect around the common carotid artery and the internal carotid artery until you have enough room around them to put in your vessel loops and clamps. Now, we have to be very careful with the vagus nerve because it usually lies in closer position to the carotid. We need to be careful not to injure it or any of his branches. Then we gently palpate the arterial wall to determine the extent of the plaque because you want to be able to get beyond the level of the plaque to ensure that you get out every part of the plaque. You want your vessel loops to be beyond that, beyond the plaque level. So you palpate gently to determine the extent of the plaque. The next thing you do is to some surgeons would want to inject the carotid sinus with 1% lidocaine. Some other surgeons don't. Some would have it ready, and when they notice there's some bradycardia or some hypotension, then they inject the carotid sinus with 1% lidocaine. Then we limit the exposure of the external carotid artery to the superior thyroid artery, which is the first branch of the external carotid artery. This is done so that to prevent injuries to other branches of the external carotid artery. Now we place the vascular loops around the three major parts: the common carotid, the internal carotid, and the external carotid artery. We place an aneurysm clip on the superior thyroid artery and a Rommel's tourniquet on the common carotid artery. We clamp the vessels in the order ICE, the internal carotid, the common carotid, and then the external carotid. And once the internal carotid artery is clamped, we start timing. Then the arteriotomy is done using a size 11 blade. A pot angled scissors completes the arteriotomy through the entire length of the plaque. And these are diagrams which I got from the internet from Aaron Cohen-Gardell's neurosurgical atlas to show how the loops are placed, how the clamps are placed, and then the arteriotomy. All right, so we dissect out the plaque from the intima. And when we do, after doing that, we inspect the wall carefully. We have to be careful when we make our arteriotomy not to injure the posterior wall of the vessel. Otherwise, that will increase our surgical time. We dissect out the plaque, inspect the wall carefully after plaque removal, and any intimal flap should be trimmed or tacked down to prevent arterial dissection. Arteriotomy closure can be done as a primary closure or with a patch graft. A number of surgeons would prefer a patch graft because they feel that it would prevent restenosis at that level. But some other surgeons feel that it's not necessary and they do a primary closure. And then we restore the circulation in the reverse order. And this is to prevent debris from going into the internal carotid artery and causing a stroke. And then we have the wound closure in layers over a drain. These are images to show the steps that I have mentioned up to the closure and how we remove the clamps in order. All right. Now, complications. Because that area has a lot of neurovascular structures, any of these can be injured and can cause some complications following surgery. But one of the most important things we worry about is the risk of hyperperfusion injury. So post-surgery, this patient will be managed in the intensive care unit, and we ensure that the systolic blood pressure is below 140 millimeters of mercury. wound hematomas can also result. So we need to closely monitor the wound to ensure that we don't have a wound hematoma that can worsen, that can cause transit nerve injury. The hypoglossal nerve, because of its relation to the carotid sheath, can also be injured. In fact, it's one of the more common nerve injuries associated with carotid endarterectomy. So as much as possible, one wants to preserve the nerve during the surgery. Sometimes some of branches of the facial nerve may also be injured on their way to supplying the face, but they are usually transient injuries and will resolve within a few months. Now, let me go on to talk about towards establishing this service in Nigeria. As we know, well, Nigeria is a very large country of about 200 million inhabitants. It's the 7th largest country in the world in terms of population. It has a mainly young population, and stroke is a leading cause of disability and death in sub-Saharan Africa. And this is very, very important for us because it means that most of the workforce are people who are involved, who get these strokes. So it's CEA, on the other hand, is a preventive strategy, and its aim is to reduce the risk of stroke or subsequent stroke and stroke-related deaths. And so this is, for me, is a very important thing that we need to look into in my country. Now, just to help us clarify or to see how important CEA is, it is said that patients with transient ischemic attacks related to carotid stenotic lesions are at risk for stroke at a rate of 12 to 13% within the first year. Carotid endarterectomy reduces this risk to about 1 to 2% per year. This is quite significant. Now, patients who have had a stroke continue to be at risk of subsequent strokes at a rate of 5 to 9% per year. This is reduced to about 2 to 3% after a carotid endarterectomy. After reading these figures, I began to wonder, why haven't we started this in Nigeria? And I spoke to quite a number of people. I remember speaking to a neurologist who told me that, in Africa, most patients have intracranial carotid stenosis rather than extracranial carotid stenosis. I tried to read around that. I didn't really find a lot of papers on that. And especially in my country, we do not have that data available. So I feel that we may need to do more studies in this regard to really appreciate that statement, if it is true that we have more of intracranial carotid stenosis than extracranial, or if we have more of tandem lesions. The other thing I noted was that we have very little documentation in literature about the evaluation for carotid artery stenosis, evaluation being use of carotid Doppler imaging or CT angiograms or MR angiograms. And this is mainly because these imaging studies are just recently springing up in the country. When I graduated from medical school in 2005, CT scans were not so common. Just a few places had CT scans around the country. But now we have a proliferation of CT scans all over the country, proliferation of MRIs. In fact, in my city where I practice, we recently got 2 new 1.5 Tesla MRIs. So the imaging studies are now available. And so it means that we may need to do more education webinars like this one to make general physicians and neurologists aware of the availability of these imaging modalities. As we well know, stroke patients will probably go to general physicians first or neurologists. They will not come directly to the neurosurgeons. And so it behoves on our neurologists or general physicians to evaluate these patients appropriately and be able to send to us. So we need to have more collaborations between neurosurgeons and neurologists in Nigeria if we're going to have patients to that would benefit from carotid endarterectomy. So that is one of the things I found out in my studies about starting up the service in Nigeria. The other thing, of course, would be the training required to get the surgical skills. The discussed with some of my colleagues as well, that we have some Nigerians who are practicing in the US and in the UK, and some of them tell me, oh yes, we have experience with carotid endarterectomy. So with regards to training, because you want to have a center that has a high volume, so that you can have very few complications, following the procedure. So the things that we may need to do to help get that training may include collaboration with our colleagues outside the country who can come back to give us, to step down the skills to us. We may need to go outside of our countries to centers that have high volume. And with the increase in carotid artery stenting all over the world, it might be difficult to get a center that has a lot of high volume for carotid artery stenosis. So we may also need to consider other training modalities, such as cadaveric training or animal models. So these are the things that I'm thinking of with regards to the training required for getting the skills for carotid endarterectomy. So to conclude, carotid endarterectomy is still a viable option for prevention of strokes and subsequent strokes in select patients, and it is important that we learn the skill for this reason. At the moment, measures are underway to make this procedure available in my country, Nigeria. Thank you so much. I really want to appreciate Professor Kato for the opportunity of spending 2 months in Japan. It was a life-changing experience. Thank you.
Thank you very much, Dr. Opara, for this nice presentation. And I think, Hui, we can start, we can open the discussion. So let me ask first, Professor Fujimura, are you still online?
Yes, I am.
Thank you. Yeah, actually, I would like to ask your experience about this kind of surgery, and maybe you can give some suggestions to Dr. Opara about how to start this kind of surgery, introduce this kind of surgery in her country.
Thank you. It's a very great talk. I enjoyed your talk. It's excellent, and I understand the impact of the carotid endarterectomy, and you also expect that to perform in Nigeria. So my comment is intraoperative monitoring is, of course, very important, as you suggested, and the prediction of hyperperfusion syndrome is also very important. So thank you. And another comment is you said in Nigeria, intracranial major artery stenosis is common rather than the extracranial. You said intracranial carotid stenosis is a little bit common, you said. So it's very interesting.
Okay, so yes, that is an opinion that I got from a neurologist. I am not sure that there is any documentation to confirm that, right? And that is why I feel that we need to have more studies done in that regard. The few papers I saw was talking about people of African descent, not necessarily only Africans. And these were studies done in the United States of having more of intracranial lesions than extracranial lesions. So I think that we need to have more studies done in that regard in our environment.
Thank you very much. And finally, my suggestion is at the beginning, in the initial experience in Nigeria, I recommend to use the internal shunting to prevent the ischemic complication. I personally make a monitoring, and I only put internal shunt for the necessary patient. But at the beginning, maybe universal placement of shunt may be safer at the beginning in Nigeria. That's only one suggestion from me.
Thank you very much.
Thank you, Professor Fujimura. Are there questions for Dr. Opara? Actually, it was an interesting talk because it's a surgery I have never performed, honestly. because here in my country, in most hospitals, this kind of carotid endarterectomy is performed by vascular surgeons, not by neurosurgeons. And I think it's also interesting. It would be interesting to know in other countries who is the surgeon performing this kind of surgery. I mean, I'm asking to Japanese colleagues, but also to Dragan Jankovic or Hui. In your hospitals, is the neurosurgeon is doing this kind of surgery or the vascular surgeon?
In my country, in Vietnam, the carotid stenosis and with endarterectomy was performed mostly by cardiac surgeon, and yeah, mostly. I don't think any surgeon in Vietnam perform this procedure. I have a question for 𝒔𝒑. After the surgery, what is the antiplatelet or anticoagulation therapy would you give to the patient?
Okay, thank you so much for your question. So usually the patient is placed on aspirin, high-dose aspirin afterwards. Some people have talked about using dual antiplatelet therapy. Some others would rather not give clopidogrel gel to prevent the risk of having intracranial hemorrhage afterwards. But usually the patient needs to be on some form of antiplatelet therapy for a long while after the procedure.
Thank you.
And have you checked the rate of complications between carotid endarterectomy and stent?
Okay, so I haven't taken time to look in that direction. And that's probably because in my country, we are yet to start endovascular procedures.
Right,
so,
right.
But it's also underway. And so it's very important that I look in that direction as well. Yes, thank you.
Yeah, of course, in the developing countries, we cannot propose endovascular therapy for all cases. It's important to offer the best option to the patients in the local setting. So, of course, in the case of your country, carotid endarterectomy is a must, so must be introduced because it's cost effectively. It's worth to be performed, of course. But in general, I think it's interesting to balance also the rate of complications between the two techniques. So I see Dr. Aniaku wants to ask a question. Dr. Aniaku, in the meantime, we can listen to your question.
Thank you so much, Professor Alberto. Congratulations to our able, capable secretary of Young African Neurosurgeon Forum. Thank you so much, Dr. Opara. That was a fantastic presentation.
Thank you.
I wanted just to know, in your hospital where you are practicing, do you have the facilities to do it? If no, what is missing? Maybe I missed that one during your presentation.
Okay, thank you very much. I would say that because I work in 3 hospitals, but where I am based full-time, I think what I would say is missing would be the intraoperative monitoring, right? What I have available in that in my environment is carotid Doppler and EEG. But I would probably need to loan it from the hospital that has it to be able to use it in my own center, right? But otherwise, I think I have every other thing. I have something for magnification. We can get the surgical instruments that are needed. We can get, for evaluation, we can have CT angiogram or an MR angiogram done. So I think just about every other thing that we need to set it up is available. Thank you.
Thank you. Any other question from the floor? So if there are no, yeah, maybe Dr. Azeged, Mikhail?
Yes. Thank you, Dr. Meda. Presentation. So, my question is, how long is the clamp time? How long long should we finish the carotid endarterectomy? The clamp time.
Okay. Thank you very much for your question. Clamp time. So from what I studied, quite a lot of people are able to finish the procedure within 30 to 45 minutes from clamp time, without having any adverse effects on the patients, especially since the patient is being monitored. Of course, for people who are just starting, that may take a longer time. So this is why the intraoperative monitoring will be very, very important. And this is probably why Professor Miki was saying that we need to probably always have a carotid shunt in situ when we're doing the procedure to make sure that we don't have problems with that when we start the procedure in our environment. Thank you for your question.
Thank you. Other questions?
So not a question, but Dr. May, congratulations on your great talk, I think. So you just start about CEA, so that you can be the first neurosurgeon who does the CEA in Nigeria, I think. So did you receive some video from our institute? Not yet?
Yes, ma. Yes, I did.
You did?
Unfortunately, when I got back home, my computer crashed, so all my videos are lost. So I need to liaise with Dr. Mikhail and Dr. Zulfikar to be able to get those videos back.
Okay.
Yes.
Then we can send it again. So maybe you can, yes, you can see you can learn the video of the repeat, watching and try. Okay. Do you have a good teacher about CA in your institute?
No, not at the moment, but I do have some colleagues who have done it severally outside the country. There's someone I know who practices in the UK, and there's someone else that practices in the US. They do carotid endarterectomies from time to time, and they are willing to teach when we do get the patients. They are willing to teach. Yes.
So you can follow them. You can learn from them, I think. Anyway, congratulations, great talk. Thanks so much.
Thank you so much, Paul.
Yeah, actually, we wish you the best of luck, May, for this kind of procedure in your country. And I also agree that if you have someone with some experience performing the first cases with you, that would be great because you can accelerate your skills doing this kind of surgery. So all the best luck to you.
Thank you very much. Thank you, everyone.
Great. So I think we can finish this session, but now we have a couple of new fellows at Fujita Bantane Hospital, and I kindly ask them to introduce themselves. So maybe we can start with Dr. Bentia first. Dr. Bentia, are you online?
Yes.
Yes, so you have 2 or 3 minutes, please, to introduce yourself, your country, and your activities.
Thank you for this opportunity. My name is Bentia Dan. I am from Romania. I am a consultant neurosurgeon in Bucharest. I work in a private hospital, in Sanador Hospital. And I want to learn vascular because in my past career I do another things. I do spine surgery, I do brain tumor surgery. I do skull-based surgery, but not vascular. And it's my dream to learn about this, and that's why I want to came here and to had this opportunity to develop this. I am interested, especially, as I told Professor Cato, in open vascular surgery, because in our country, in Romania, endovascular procedures are made by radiologists, interventional radiologists, 100%, unfortunately for me. This, and that's why I want to perform and to learn in those 2 months about open vascular surgery. I'm very grateful, and I hope we'll manage with this. Thank you very much for audience.
Thank you, Dr. Bentia, for this self-introduction. And now I ask Dr. Zulfikar. Dr. Zulfikar?
Now, can you hear me?
Okay, yes, now we can.
I'm actually not the new fellow here. It's been 1 month here that I'm here in Japan, in Bentane Hospital. I'm basically from Pakistan, and I'm working there as a consultant neurosurgeon in Northwest General Hospital with Professor Tariq Khan under his mentorship. He's a very well-known person. He has been WFNS chairman for the trauma committee. And my time in Japan has been very good, and a lot of new experiences, new equipments, new surgical techniques, especially in the neurovascular as well as in the endovascular. And at times we go to other hospital as well to see some pediatric procedures or some hands-on workshops. We attended some conferences here in Hiroshima, where we met with Dr. Filippi, and to Tokyo as well. So the time here is very good, and I hope the next month is also a nice experience. Thank you.
Thank you very much, Dr. Zulfikar. I think we don't have others, right, who have to introduce themselves from Fujita Bantane Hospital. Professor Cato told me that she will have 2 new fellows from Ukraine soon.
Sorry.
I think we have the Dr. Niraj.
Oh,
One
yeah.
more.
Go ahead.
Yes,
One more. Go ahead.
Namaste. I am from Nepal.
Yes, please introduce yourself, Dr.
My name is Neeraj Gimre. I work as a neurosurgeon at Nepal Medical College since 2022 November. I did my neurosurgery training from India, New Delhi, under the Professor Daljit Singh and the Professor Anita Jagatia. Actually, I came to this hospital to be trained under Professor Cato to learn more about vascular surgery, both microscopic and endovascular. In few days, only in just 10 to 12 days, I have learned a lot here about decision skills in vascular surgery, about clipping of the aneurysms, bypass surgery I have seen, and so many endovascular procedures I have seen here. It's my luck and I'm honored to be part of this alumni, and I have attended so many conferences, 2 or 3 conferences just in few days, and I'm very grateful and honored to be here, and I hope I will learn more. And thank you, Professor Cato, for giving me this opportunity. Thank you very much.
Thank you so much, and we all wish you a very good luck for your Japanese experience. I'm sure you will bring back to your countries a lot of experiences, a lot of inspiration, which is very important when we go back to our countries and try to develop as much as possible our surgical activities. So,
thank you.
Probably, yes, we can end this webinar now, but first I would like to ask Professor Yoko Cato to say some conclusive words.
Thank you so much. Fujimura Sensei, thank you very much for waiting till the end. So even today is a Sunday. So that we learned a lot from him, especially that we done such kind of a corridor channel. Maybe I think that word is very new for all of you. I think that he is expert of the bypass, and not only bypass, but especially the bypass area. That he is the #1 in Japan, in the world, I think. And also the May, she started about the CEA. She has a great interest about CEA. Then she will be the first the neurosurgeon in Nigeria, I think, to do the CEA surgery, I think. It was wonderful, the webinar today. Thank you very much.
Thank you very much, Professor Yoko Kato. And let me thank also the two speakers we had today, Professor Fujimura and Dr. Opara, for wonderful lectures and very, very interesting discussions. Thank you, Dr. Kabulo. You have been a great discussant. And thank you, Dr. Hui, who has been my co-moderator today. So I wish you all a great day or night, depending on where you are in the world. And the next appointment is in 1 month, in August, with another edition of our Fujita Alumni Association webinar. Thank you very much and see you next time.